Shoulder pain is extremely common indeed because the shoulder is one of the most mobile joints in the body. The mobility allows us to lift, rotate, and reach in almost any direction, but it also makes the joint more vulnerable to injury. The most common causes I see in my clinical practice include rotator cuff disorders, which are the tendons moving your shoulder around, subacromial impingement syndrome, where you have the bone above the tendons rubbing to each other. The frozen shoulder essentially can be progressive stiffness and restricted movement following a trauma or related to diabetes, shoulder arthritis, which is the common wear and tear, but also shoulder instability following a shoulder dislocation after an injury. It is important to know that not all shoulder pain originates in the shoulder itself. Sometimes it is referred from the neck, which is why careful assessment is essential. Many mild shoulder problems improve with rest, simple pain relief, and activity modification indeed. However, specialist assessment is important if the pain persists beyond a few weeks, the pain is worsening rather than improving, there is nighttime pain that affects your sleep, if there is weakness or difficulty overall lifting the arm, the movement becomes restricted, or the shoulder becomes very unstable. As an orthopedic condition, persistent shoulder pain should not be ignored. Early diagnosis by a specialist can prevent long-term problems such as stiffness, tendon tear progression, or a joint damage. If shoulder pain is affecting daily activities, work performance, or sleep, it's time to seek expert advice. The diagnosis always begins with a detailed history and conversation with you. I ask about how and when the pain started, what are the movements that make it worse, whether there was a trauma included, and the effect on your daily activities. Then I perform a thorough clinical examination, assessing the posture, the shoulder alignment, active and passive range of motion, but also the muscle strength. There are specific clinical tests that help identify specific conditions, such as rotator cuff problems, impingement, or instability of the shoulder. If following this imaging is required, this is tailored to the individual patient. X-rays is a good start assessing the bone structure, and it can be followed when needed by ultrasound scan, which allows dynamic assessment of the tendons in real time, or MRI scans to provide more detailed information. It is important to understand that not every patient needs every scan, and the key is to combine the clinical expertise with targeted imaging. Treatment depends on the underlying cause and severity of the symptoms, but most shoulder conditions improve without surgery, to be honest. The first line approach is always non-operative management. The majority of the patients benefit from activity modification, structured physiotherapy to restore the motion, some painkillers, including anti-inflammatory medications, but also targeted corticosteroid injections in selected cases. A stepwise approach is usually adopted along with the patient, and a significant number of these patients have improvement without any operation. Surgery may be recommended if there is a full thickness rotator cuff tendon tear, significant instability affecting daily activities, advanced wear and tear arthritis, or persistent pain which is not improving following non-operative management.